Aloha and good morning from the Hawaiian Eye Conference in Maui. We're pleased to be here today with Dr. Audrey Rostov from Seattle, Washington. Thanks a lot for being with us.
Great, thank you. It's a pleasure to be here.
Audrey, I know that one of your sessions at this meeting has been about femtosecond assisted cataract surgery for complex cataract cases. What a fascinating application for this great technology. I'm curious if you can walk us through a couple of examples and ideas about how the femtosecond can help in these very complex cataract situations.
Absolutely. I'd say two really good indications for using the femtosecond laser with cataract surgery are dense white or intumescent cataracts, because it makes the capsulotomy a lot safer than with a standard manual capsulorhexis or capsulotomy. And the other case is with zonular compromise. Your pseudoexfoliation patients, for example, or anybody where there's trauma or you suspect or know that there's weak or missing zonules. This can really be mission critical to success in these cases.
Those are some great examples, Audrey, and I'm just wondering if you can spell out for us, why is it that the femtosecond is useful in these zonular weakness cases? What is it about that technology that helps our surgery?
It basically puts the least amount of stress on the zonules, and so there's no tugging or pulling. You have the capsulotomy when you dock the laser there. The capsulotomy is done. It's quick, it's efficient, and you don't have that same concern about getting an Argentinian flag sign, for example. Love Argentina, but not in my OR.
That's a great point. I want to go back to what you were speaking about earlier about pseudoexfoliation cases, because as you mentioned, these can oftentimes have weak zonules, and we want to try to minimize the stress on the zonules as much as possible. But as well, another feature of pseudoexfoliation tends to be smaller pupil sizes. So I'm wondering, how do you approach a femtosecond type procedure in a pupil that might be smaller than average?
Well, a couple of things. Preoperatively, I really think that it's mission critical to use both an NSAID as well as 10% phenylephrine. And using this combination along with some Adriacil, I find it's pretty rare that I can't get the pupil to dilate enough to do my capsulotomy. In addition, sometimes you may have to adjust the size of the capsulotomy. You might have to go a little bit smaller. However, it's pretty rare, I would say, that I need to do anything else. In those rare cases, you can, if it's efficient for you and if that's a possibility, you can actually go in, you can inject some viscoelastic, you can even put in some sort of ring pupil expanding device and then do your capsulotomy after that.
That's a really great point, Audrey. Another thing that I'm hoping you can share some pearls for us is about anesthesia, because as we know, as the femtosecond is a new technology for us in ophthalmology, we're still sort of working out how the logistics of the operating room flow works in each center. And in some centers, patients are receiving anesthesia prior to femtosecond, and in other centers they aren't. And for some patients, this can be a sort of scary technique if they are going in without any anesthesia other than topical. What are some potential workarounds that you've found in order to help deal with that?
Well, in our center, we're very, very fortunate because we have our two ORs, and then we have a third space, basically a sort of an OR or an area where we have our femto laser. And so the patient does have IV access, and we have our CRNA just administered just like a little whiff of midazolam right before the femto procedure, and that tends to work very well. Of course, what I call just basically verbal anesthesia, just talking to the patient, guiding them through, I think that there's absolutely no substitute for that, and that can just be very gentle and very reassuring. There's also the new MKO Melt sublingual anesthesia that works quite well. I personally have not used this, although I do have many colleagues who use it and report good success. And so I'd say any kind of combination thereof can give good results for patients and make them more comfortable during the procedure.
That's a really great point, Audrey. One last thing I hope we can touch on is back to a discussion that you brought up earlier about very dense cataracts and white cataracts being a useful adjunct to use the femtosecond in those procedures. But I'm curious, how do you go about making sure that your centration is correct in the sense that patients may not have good vision out of the eye in which you're operating? They might have hand motions or sometimes worse vision. How do you get patients to fixate onto the center of the femtosecond platform in order to get a centered treatment?
Well, I think that it's almost not so much the patient fixating as much as it is you're being able to center the suction ring or the patient interface device. And so if you have good centration there, and then if your femtosecond laser allows you to do, you can have a pupil centered or optical center, and so you basically have that flexibility. And so in some ways, even if the patient can't fixate, it doesn't matter that much as long as you yourself can get the good centration. And that's really very easily doable with a lot of the femtosecond laser platforms.
Well, Audrey, this has been such a great summary for us of some of the pearls on how femtosecond-assisted cataract surgery can be useful in challenging cases. Thank you so much for sharing your expertise.
Mahalo. Thanks.